Yeah, hello everyone. Very warm welcome to you all, wherever you are right now. After a little summer break of our webinar series in 2023, we start today with a new one. And my name is Stefan Baudis. I'm VP Global Affairs at CytoSorbents Europe. And I really have the big pleasure to moderate this webinar today. The title is Anticoagulation during liver support therapy, easy or challenging? So before we start with that, I just like to add some comments here. As always, we have the possibilities to get your questions in the chat, and my dear colleague, Dr. Volker Humbert, is in the background and will try to answer these questions. If he's maybe not able to do that, of course, we will give these questions to our experts and speakers. Yeah? And for all the people who want to get a certificate for this webinar, you really have to attend this webinar till the end, because we then have a little poll for you, and you can just mark if you want to get a certificate, and you will get one a little bit later via email. Yeah, but now it's time to introduce the speakers and experts. And I really have the big pleasure to welcome here Dr. Ivano Riva first from Bergamo in Italy, from the hospital Papa San Giovanni. And this hospital is one of the biggest liver transplant centers in Italy. And Ivano has long-term experiences with different liver support systems, and of course with liver failure patients. And that's why it's a big honor to have him here today. Hello, Ivano. Buongiorno.
Hello.
Or buonasera.
Hello, everyone.
Yeah. And the other expert and speaker later on is Professor Janos Fazakas from Semmelweis University in Budapest, from the Department of Anesthesiology and Intensive Care. And a warm welcome to you, Janos.
Thank you for the invitation. Hello for everybody.
Yeah, these two experts have one thing in common. They are, of course, experts in liver failure, but in addition, they have really long-term experiences with liver support systems, and I think this is a perfect bridge to what we want to do today. We want to talk about the usage of liver support systems in liver failure patients and the question how to best anticoagulate these patients. And Ivano just recently published a very interesting publication about the use of liver support systems in 39 liver failure patients, and he compared them regarding the efficiency of removing different substances like bilirubin. And for this reason, I like to hand over to Ivano and talk a little bit about his latest publication and results. And the floor is yours, Ivano.
Hello to everyone. Thank you for the invitation in this webinar. So in this 20 minutes, we are going to talk about the anticoagulation in the extracorporeal liver support, and in particular in the regional citrate anticoagulation, if it's easy or challenging in the liver patient that we treated. Of course, we have to remind the indication of the artificial liver support that, of course, are the acute liver failure with all etiology, but even to the acute and chronic liver failure that are difficult patients because they not have the chance of the transplantation. So we have to try to regain the hepatic function and to bring this patient to the recovery. So in Bergamo, we started in the 90s to use the first machine that we have to use. It was the Mars. We treat some patients with the Mars, of course, with acute liver failure. Then we try even the Prometheus, the other machine, the other technique to depurate the blood of the patient from the liver toxins. And then we go on with CPFA, the coupled plasma filtration absorption in the early 20, the 2000, and then the single pass albumin. So we tried, I think that we tried all the technique that are available to treat the acute liver failure, the acute and chronic liver failure of this patient. And then in 2015, in our center, we started to use even CytoSorb. That it's a little bit different approach, because it's a cartridge and it's not a machine. It's a cartridge that you use with all the CRT machines without any problem. So it's a different point of view to treat this kind of patient. And so this is our experience, our Bergamo experience from 2008 to 2019, in which we compared all this kind of treatment, of course, CPFA, Mars, PAP, Prometheus, and the CytoSorb. And we can say that we observe a really difference in capacity, in capability of the extraction of the liver toxins between the different techniques, of course. And to compare this kind of techniques, we don't use, as other papers, the reduction rate that is a single determination of this extraction of the technique of the machine of the liver toxins, but don't account as the capability of the technique to depurate the blood of the patient. So we decided to use the mass balance, because the comparison in the mass balance, in the total of the removal with all the treatments of the liver toxins, in particular, of course, bilirubin and bile acids, we have a more precise picture of the extraction of this patient, of the purification of this patient, because we have to take in account even the continuous production of, for example, for bilirubin, or the bilirubin that comes from tissues to the blood of the patient. So using the mass balance, of course, we believe that it's a more precise picture of the efficiency of this kind of techniques. And there are here our results, and we can say that, of course, with CytoSorb, we have even 5 times absorption in comparison with the other techniques, of course. We observe these results, but we can say that even the major duration of the treatment, because CytoSorb lasts even 24 hours for each cartridge, then the other techniques can give the explanation of the higher absorption of CytoSorb. But it's not the only one motivation, the only one question, because we can see in this picture that CytoSorb extracts even more than, for example, CPFA in this case, for all the point of measure during the treatment. So the total duration of the treatment is important, but it's not only the motivation in which CytoSorb can extract more and more bilirubin, bile acid, and the liver toxins. So we can see in this table the duration of the treatment, and we can say that Mars lasts 8 hours, PAP 6 hours, Prometheus 4, CPFA 7, then CytoSorb 24. So we can say that the duration of the absorption, the real time of treatment of this patient, it's very important to get a real important depuration of these liver failure patients. So the real time of the therapy is important, is crucial. And so what is crucial to get this duration, of course, is the anticoagulation. So the anticoagulation is really the crucial point of this treatment. And so we have different modalities of anticoagulation, okay? Of course, before the advent of the citrate, of course, we use the heparin. Heparin is anticoagulation. That is a systemic anticoagulation, of course, but have some problem because can induce the heparin-induced thrombocytopenia. That is a very big problem in this patient. Of course, in the liver patient, in which there are, we have, of course, the thrombocytopenia for the cirrhosis or the acute liver failure. We have in this patient the reduction of antithrombin, and so we have the reduction of the inflammatory effects of this protein. And in many patients, we can observe even a heparin resistance. So even you go up with the dosage of heparin, you don't get adequate anticoagulation in these patients. And so it's not so easy to get the duration of the treatment using heparin. Of course, even less with the low weight molecular heparins, because we have a big problem of accumulation of this kind of heparin. And so we have a bleeding risk of the patient very, very augmented. Because we have to take in consideration the bleeding risk of this patient, because we know that in the liver patient, in particular in the acute liver patient, we have a great impairment of the coagulation system. And so even, I think, in the liver failure, acute or chronic, in trauma patient, or even post-hepatectomy patient in which we have liver failure, the bleeding risk is very, very high. And so to use an anticoagulant, a systemic anticoagulant as heparin, probably is not the best choice for this patient. And we can observe in this study of 2017, the bleeding events, the percentage of the events in this patient, we can see that in all these studies are higher with heparin than with the regional citrate anticoagulation. So it's very important because we know that the bleeding is a bad trigger point for the liver patient. Otherwise, the regional anticoagulation with citrate, we can observe a reduction in bleeding risk of this patient, in the reduction of the need of transfusion. That it's another problem for this patient. And we observe in this picture an augmented lifespan of the circuit and the filter. So we can say that we are less clotting of the filter using regional citrate anticoagulation, because we have to remember that citrate is forms a complex with the calcium ions, making unavailable for as a cofactor of the coagulation cascade. And so we get the anticoagulation of the filter, only of the filter, because of course the citrate is dialyzed from the filters in majority, more or less for 60–70%, and the remaining part of citrate come back to the patient and are metabolized from the Krebs cycle in the liver or the muscle of the patient. So it's not a problem, because we obtain sodium, free calcium, and of course bicarbonates ions. That is the final destination of the metabolism of the citrate. So the citrate can allows us to have a real regional and not systemic anticoagulation. That is our goal, because we need to anticoagulate the filter and not the patient, of course. We have to keep the calcium ionized level in the filter between 0.25 0.4 millimole per liter. and in which we can get the real anticoagulation. Of course, all this is true in a patient with a liver that is normal. We could have some problem with the liver failure, of course, because the metabolism depends, of course, of the liver function, but even of the level of the oxygen, because is a metabolism oxygen dependent. But we have to remember that this paper says that this one from 2015, we have a real augmented lifespan of the filter. And we can say that the survival of the filter is higher with the citrate use than with heparin. And so we can assure to the patient a really dialysis dose and absorption dose. That is our goal, because we have to treat this patient with absorption. It's very important. So the longer absorption continues, the better is for the patient, of course. We have this review from Cochrane, which compare the heparin with the regional citrate anticoagulation, in which we can see that the prevent of clotting is not so different, but it's a review. It's only 100 patients, so not so big the number of the patient considered. But we have a significant difference in the major bleeding. We have a reduction, a significant reduction in bleeding with citrate than with the unfractioned heparin. And as we said before, it's very important not to have a liver patient bleeding, because it's a bad trigger for the worsening of the liver function in these patients. So this review have some problem, because, for example, these ones as an exclusion criteria, the liver failure. So all this one, it's not really good to classificate the difference between heparin and regional citrate anticoagulation. But in any case, we can see that with the using of the citrate, we have a reduction in blood clotting of the filter. And of course, the reduction of blood clotting causes a reduction of blood loss, because if you have to change all the circuit of CRT with the filter, the patient, of course, lose a part of his blood, his volume. So it's better to have a reduction of clotting, because we have a reduction of blood loss of the patient. And of course, and not so, we have to take consideration even the workload of the nurses and of the physicians, because changing the circuit of CRT, okay, causes an augmented workload for the nurses. In these papers, we can see the reduction risk of bleeding in the use of citrate, and someone in this second paper of 2023, so very in this year, we can observe that the using of citrate reduce even the activation filter induced of the complement in the filter, and the granulation of the neutrophil, so with augmented release of cytokines. So the use of the citrate can have to render the filter more biocompatible, less prone to the clotting, and so can reduce even the inflammation inside the filter, that it's a trigger, of course, of coagulation of the filter. In this paper, we can go to the patient with a liver failure patient, and this paper we can say that they observed that after 72 hours of the use of the regional citrate anticoagulation, we observed a shift toward a metabolic alkalosis of the patient, not to metabolic acidosis that is due to the accumulation of citrate. And so we can initially say that probably the use of the regional citrate anticoagulation is not so bad, even in the liver patient with the reduction of the liver function. They observed that, of course, an augmented lactate in the blood is a prediction of accumulation of citrate. And of course, as in literature is known, the ratio between total calcium and ionized calcium reflect the accumulation of citrate, of course. But in this paper, no severe decrease in ionized calcium of the patient was observed, and even with accumulation of citrate, they don't observe in this liver patient the significant disturbance of acid-base balance of the patient. So we can say that the citrate accumulation in this patient correlates quite well with the ratio of total calcium and ionized calcium. And so they conclude that the using of citrate in CVRD in this patient is feasible, it's not harmful. Then we can go to these two papers in which we observe again that there are no significant variation in the pH of this patient, even use a citrate in the liver patient using the citrate compared to the use, of course, of the heparin. And so they conclude that probably it's a good thing to use citrate even in the liver patient, in liver failure patient. In this on the right, they compare the use of the SLED dialysis in liver patient using the citrate. And they observe, as in this picture, that we have accumulation of citrate in the first hours of a treatment and then come back to the normality after at the end of the SLED treatment and even more 24 hours after the treatment. So they didn't observe any major acid-base disturbances in this patient, and even in this paper, no severe decrease in ionized calcium observed. But of course, they say that it's very important, the close monitoring, of course, of the patient and of the calcium of the patient. So we can say the citrate is not toxic per se, but it's toxic when it causes, of course, hypocalcemia. And so we go on with this other review in which they use the extracorporeal liver support using anticoagulation, comparing heparin to the resonance citrate anticoagulation. They use, of course, MARS and plasma exchange. And they didn't observe any difference between techniques about the lifespan filter, of course, using the citrate, and the ratio of the accumulation of citrate is more or less 5% in this patient. And even in this work, they didn't observe any acid-base alteration. So the conclusion of this paper is that the use of citrate anticoagulation, regional citrate, is effective and safe even in extracorporeal liver support treatment in, of course, liver failure patient. Of course, even in this paper, it's said very, very clear that we have to have a close monitoring, of course, and the timely adjustment are needed, of course, during the treatment to maintain, to keep the patient stable in this case. Something interesting in this case, they produce a protocol of automatic protocol in patient without complete metabolism of citrate. And so they augmented, of course, the dialysate flow to dialysate more or less 70% of the citrate with the filter, and they didn't observe any variation, even in pH of the patient, in the calcium and in the bicarbonate. So in this experience, it's only one, but it's useful. They didn't observe any variation, even without metabolism of citrate in this patient. Another review in which we can say the same thing say before, because they didn't observe really a variation between heparin and citrate, but they didn't take in consideration the risk of bleeding. And so I don't know if it's a good thing not to take consideration the aspect that it's crucial in the liver failure. But the conclusion is always that citrate is effective and safe under, of course, close supervision. Very, very fast, we can speak about our experience in Bergamo. We treat this patient with citrate, and we have the cytopenia of this patient, of course, in this axis, compared to the ratio of calcium. And we, of course, is a preliminary data, but we can say that probably the cutoff of 2.5 for the ratio to avoid the citrate accumulation, this patient, child C, class child C, or with acute liver failure, it's better to consider it 2, not 2.5. But of course, it's only our experience and in preliminary data that we are, of course, studying in this month. So the conclusion rapidly, we can say that all the extracorporeal liver support techniques are effective in remove bilirubin by lysing. We observed, of course, a substantial difference in the duration of the treatment for each type of this extracorporeal liver support technique. And we have to stress that anticoagulation is essential to get the right dose. And regional citrate anticoagulation, in our experience, is the best, is the most effective choice. CytoSorb, of course, we can use with any type of CRT or hemoperfusion. Of course, the superiority to the other CLS we have demonstrated in our data, of course, even to the longer duration of the treatment. And we have to say that we have no release of the absorber molecules even after the 24 hours of using. And so we can say that the effective absorption time is crucial. So the duration of the lifespan of the filter is crucial. Regional citrate is safe even in failure patients, in liver failure patients, of course, but we have to close monitor this patient, in particular the duration of the calcium. And so we can act with the variation of blood flow or citrate blood level in the patient, dialysate flow, or calcium supplementation to get our patient more stable than is possible. As I said, probably in severe liver failure, the duration is better to keep under 2 than under 2.5. Of course, we, as the literature said, needed more trials to adjust the regional citrate anticoagulation on the different degrees of the liver failure of the patients. Thank you.
Yeah, thank you very much, Ivano. I think that was a very comprehensive talk and a great overview about the usage of citrate in the moment. But of course, there are sometimes problems, yeah, and there might be pitfalls, and we want to touch that and we want to mention that, and that's why I think we gonna switch to Janos' presentation now, because we don't have so far no questions, but maybe we can have these questions and discussions after Janos' talk. So please, Janos, let us learn about your experiences over the last, I think, more than 20 years, yeah, of course. Yeah.
Thank you so much, Stefan. Yes, 20 years, 25 years. I had used Mars system, the Prometheus in pediatric, in adults for bridging, postoperatively. Mainly I work in the liver transplant field, so I work. So yes, we have experience, but nowadays we use the citrate, of course. So my topic is about anticoagulation liver failure patients, pitfalls and lessons learned. It will be more practical one, not scientific one. According to the technical data, we know that the extracorporeal blood volume, it's important, must be below 10% of the patient blood volume. Because of that, 300 mils must be kept in mind. The blood flow, of course, is important. Usually in liver failure patients, we need 100-150 mils per minute. The treatment time, yes, could be 8 hours if it is a bridging before the liver transplant and you run in the OR because of the transplant, or could be 24 hours when you do a treatment. But you should keep in mind that this adsorber is pre-filled with isotonic saline. Why is important? Because from practical point of view, there is a priming of the adsorber, and this is done with 1.5 liter of saline. And you have many choices. If you would like to be on the safe side, then you could prime it with 500 mils of saline, which contains 500,000 units of heparin, or 1 liter of saline with 10,000 units of heparin, and the remaining 1 liter or half liter is for flushing out the heparin from the adsorber. Why we do this in some condition, not in every patient, it is an option, because this heparin can stick to the adsorber, and it gives you a better anticoagulation at the beginning. Technical possibilities, it was shown before. We can use hemoperfusion independently. We can use a CVVH or CVVHDF, and the adsorber could be before the filter or after the filter. It's very easy. It means that we give a CRRT, but we put the adsorber in the system. You can see here a multifiltrate device. The modality is hemoperfusion as we choose. We have the adsorber, we have the priming set when we do the priming with saline, or with saline with heparin, it's up to you. And we use also this priming set during the treatment, so you don't need a separate adapter for the application of the adsorber. If you use multifiltrate in CRRT, we have the CVH with the dialyzer and the CytoSorb adsorber, but the adsorber is before the filter. Please keep in mind that you should use the priming 1 tool for priming, and you have an adapter number 1 as tool when you can adapt the adsorber before the filter. This is quite important. If you use a Prismaflex, then you can use it also in such a way that the adsorber is after the filter. In this case, you should use the priming number 2 tool for priming, and the adapter number 2 as tool to get your adsorber behind the filter, the dialyzer. Well, possible pitfalls and complications. There are a lot, but what is more important that they are more or less the same as with other extracorporeal procedures. Mainly, we have complication related to the patient. So during the treatment, sometimes the patient condition is changed. And this is the first rule that you should check. Something changed in your patient condition in hemodynamics, because this could be the cause and not the system itself. Then the second is a very, very common that according to your venous access, you have technical problems. Your blood flow given by the venous access is inappropriate. And the third one, which is common but not really observed by the physician, then your setting in the ratio between the blood pump and replacement fluids pump ratio in the setting, it's not accurately done. What will happen? You will have an increased hemoconcentration at the filter or at the adsorber, depending from their place, and it will. In this case, you should reduce the pump speed. You should check that maybe your ultrafiltrate is too much, or you give the fluid replacement is too much. So basically, usually in this case you have a high venous pressure, you should check it. So these three it doesn't mean that your anticoagulation is inappropriate. It means that patient condition changed, your IV access is not good, not functional properly, and your pump setting is not set it properly. And of course, we have the problem when or anticoagulation is inappropriate. Possible pitfalls and complication is hypovolemia and hypotension, which occur during the treatment. Of course, these will cause blood flow reduction and so on. And the extracorporeal blood volume maximum must be less than 10%. You should think about that. Yes, we need in these patients some volume replacement. During the volume replacement, we reduce the ultrafiltrate rate, and we could have hypothermia, so we need temperature control and heating on the stems. Anemia, very important. Usually these systems are working properly when the patient hemoglobin level is between 90-100 grams per liter. And of course, electrolyte disturbances. Air embolism and hemolysis means end of the treatment, but this is also in every CRRT. Well, allergic reaction, according to the CytoSorb, is something theoretical. It's not practical. The most common two alarm forms which you will observe from two segment signals are related to the IV access technical problems. Sometimes you have a negative arterial pressure alarm, which means that maybe your blood flow is too high compared to the volemic condition of your patient, or it's more or less common that you have some IV cannula blockage or breakage, or some thrombus there, or positioning problem. So basically, it's an IV axis problem. Then, but this is not. It's only in 2-4% of the patients that you have this negative arterial pressure alarm. Then you could have this high venous pressure alarm. This is because of the positioning of the IV access, mainly occurs in the femoral vein region. And of course, you could have also clot in the venous line. How you can avoid this? You should use cannula with the tip, which gives you a laminar flow. You can see on the slide, this cannula is very good for CytoSorb CRRT treatments. It's better than you use another cannula where you have side holes, side spots, and you could have a turbulent flow. Turbulent flow means coagulation, always. Other two alarm forms are related more to the filter dialyzer or the absorber, depending where they are sited before or behind of each other, or the pressure derived from them, because the pressure, you will have a pressure alarm. These are technical problems, high filter pressure. The filter or absorber is clotted. The clot is in the venous part, or you have and this is very common, a high replacement fluid rate. So what I said again, the ratio between the pumps and the volumes which are set in the treatment are very, very important. This doesn't mean that you do not have a good anticoagulation. It means that that anticoagulation is not good for this setting, and or hypovolemia. Or you could have a high TMP pressure. Of course, the membrane permeability decrease, but not for clotting because of clogging, or the replacement fluid rate is not adequate. It's too high, or whatever. And the absorber capacity could be decreased. If you have a breakdown with a rupture, of course, this, as you see in the picture, is the treatment read, but this doesn't mean that it's your fault. It's the fault of the system. The CRRT circuit and the chambers could have technical problems. You could have air bubbles in the bloodline. Why? Because your screw connection are loose. These loose connection, improper rinsing could give you some bubbles and foaming around the adsorber. And so you should prepare your adsorber and do not let air in the adsorber. But what is more common, that you over-tight the screw connection, and because of that you will have a longitudinal rupture on the site, and then some air bubbles can get in. So this could be a reason, and you can see the chamber, we have clotting. This is the sign. Clotting the bloodline. Excessive hemoconcentration, as I said, this is the problem that the physician had an improper setting of the different pumps. And inadequate anticoagulation could be, of course, but as you had seen, the patient condition, the IV line condition, and the pump ratio are the first three before that. Anticoagulation must be effective before starting the treatment. You should check your patient before start the treatment and adjust everything in a such way to be ideal. What is the ideal anticoagulation during these extracorporeal treatment in acute liver failure? Yes, we need a suitable anticoagulation effect and low risk bleeding, minimal systemic adverse effects, short half-life, and proper bedside monitoring opportunities. And of course, we should need an antidote. For my meaning, as the previous presenter, the citrate is the best in this condition. In the past, I have used heparin with 83, without 83, only. I had used sometimes LMVH. In one patient, prostacyclin, it doesn't work. We don't have proper monitoring in these. Thrombin inhibitors, there are also a choice. But basically in cardiac patients or cardiac surgical patients where the systemic anticoagulation is needed, not only the extracorporeal one, and the best is the citrate. Administration of citrate in the front of the filter, quite important. Of course, you should check the regional hypocalcemia after the adsorber, after the adsorber and dialyzer, depend where they are sited. But there is a common fall, what could happen, that you should, of course, you should replace calcium and you maintain the normal level in the patient. But you should please do not do that if you have three lines, an arterial venous line for the CRRT, and you have another one to put the calcium at the same side where the blood flow is given or received back from the system. You should use another separate vein far from this side. Citrate anticoagulation has benefits because it's safe for high bleeding risk, and liver failure means high bleeding risk. And of course, in case of heparin-induced thrombocytopenia, and acts as a buffer. So even in severe metabolic disorders, it could help us, because if the liver 20% is functional, you will have the Cori cycle and you will have some bicarbonate. The fears are the citrate, according to the citrate metabolism in liver failure, that is inadequate in very severe liver disease. Then we will have citrate accumulation, metabolic acidosis, and systemic hypocalcemia. Of course, we do the close monitoring of the by ABG, of the calcium, or of the pH, of the bicarbonate, and the different electrolytes. The risk of citrate toxicity in fulminant liver failure or in this condition of shock where your patient liver doesn't get a proper flow from the systemic side yes, it's present, and as you said, had heard in the first presentation, is around 3–5%. Citrate toxicity, of course, metabolic acidosis, decreasing the systemic calcium. You need to give more and more calcium to your patient, and what is quite important, and the previous presenter told us, you should check the total calcium and to the systemic calcium ionized ratio. So the calcium ratio is quite important for monitoring. And you can reduce the citrate toxicity by reducing the citrate dose, reducing the blood flow, the speed of the blood flow pump. Of course, by that you should give the treatment more in time, more. But we had seen that we have 24 hours. So by blood pump reducing flow rate, it's not quite a problem. And this is my conclusion slide. So in liver failure patients, these patients did not lose all the liver citrate metabolization function. But keep in mind, the patient blood must pass through the liver. And we had seen that 70% of the citrate is eliminated by the dialyzer and so on. The remaining part, 30%, is metabolized by the failing liver, is metabolized by the kidneys and the muscles. You should check the blood flow in the failing liver by ultrasound before the treatment. This is my option in my practice. Always I check what is going in the failing liver, what is coming out from the failing liver, portal vein velocity, hepatic artery velocity, resistivity index, and the hepatic vein velocity, and the flow. Because usually if I have a flow which is, as you can see in the portal vein, usually is less than 20, the hepatic artery is 30, it means that if in the failing liver, 20% of the function is remained, and I do everything that the blood will get in the liver, get out, so the blood must pass through the liver, I will have metabolization of the citrate enough. So check the flow. The second, these failing livers are hepatic artery dependent. They get the most of the flow by hepatic artery flow and the oxygenation as well. So please keep in mind that you should check the mean arterial pressure because of the hepatic artery. And of course, you can use also some albumin. You can think about the other option as well. And keep in mind, when you have clotting, it's always you think that anticoagulation was inappropriate. In 70% of the cases, something happens in your patient condition which you do not observe or you do not treat properly, actually. Then, very common, you have venous access problem. Your venous access is inappropriate. You should keep in mind. Then you should check the pumps and fluids. I mean the pumps, the blood flow and the replacement fluids. The ratio between them is inappropriate. And all these three cause clotting. Because if you optimize everything in the position 1, 2, 3, then your anticoagulation will be appropriate with citrate. Yes, we need the rigorous diagnosis criteria for citrate accumulation, but only from 100 liver failure patients, only 3–5 patients will be observed with some citrate accumulation. And of course, we have another opportunities in these patients to reduce the citrate, to give something besides. This is something else. Thank you so much for your attention.
Yeah, thank you very much, Janos. That was really a fantastic overview and very practical hints for the daily use. I would like to start with the first question. You were mentioning, of course, that citrate is the best, but what should people do if they don't have access to citrate?
If you don't have citrate, you have heparin. Everywhere in the world, all over the world, we have the heparin. If you have 83 besides, as coagulation factor replacement, because in liver failure, the procoagulant factor levels decrease, but the anticoagulant level factor decrease more. So that is a myth that the liver failure patient is it's a bleedy patient. 70-80% of these patients are with high thrombin generation and more procoagulant. So what we did in the past, not now, because not nowadays we use the citrate, we replace 83 to be minimum 20% above the procoagulant factors, as example, the prothrombin levels. And of course, we use heparin. In these cases, we did we did the priming of the adsorber with 5,000, 10,000 of heparin according to the patient condition. And at that time, this works. And of course, during the treatment, you need a more close monitoring compared to the citrate. Really, you need it hourly or every half hour. It depends from the patient condition. If the patient condition changed, if your IV access, it was a problem. If your ratio, because you think that I need this or that, and maybe your blood pump and every pump flow velocity, it was not in ratio. Then of course you need more treatment. But every time when you have a big problem in the circuit, you should keep in mind that the blood will be coagulated in 5-6 minutes, or the circuit or the adsorber dialyzer. So if you react, you should react as in Formula One, when they are that speedy tire changes. So you should have in your mind what to do. Well, we gave heparin, and we gave 83. Even we have some patients during the liver transplant, we did also CytoSorb treatment, and we use in 1 or 2 patients, we used only 83, but it was given accurately before the adsorber, 800 units. But this was the past. Okay. The citrate is the present for us, and maybe for the others also will be the future.
Do you agree, Ivano?
Yes, I think that we have no other options, because if you want to have a really efficacy of this treatment, you have to keep the right anticoagulation. So I think that even in our experience, more problem with heparin than with citrate, because we really didn't observe any clotting of the filter with the citrate, even after 17 hours of treatment, and in which we have a clotting, it's due to the catheter or other causes than not the citrate, of course. And up to now, with the machines that have some protocols, some automatic protocols for the use of citrate, is easier to keep stable the patient. Of course, the physician have to be there, have to see the calcium, have to be aware to the changes needed from the patient, of course. But I think that in the liver patients, we use the citrate without problem, and I think the only one situation I remember is the accumulate of the metformin, the intoxication of the metformin, in which are completely block the metabolic pathways, and so there you can use the citrate. But I think that it's the only one case in which you cannot use the citrate. In all the other situation, even during the transplantation, you can use. I think with safe the citrate, because it's really efficient, and you can get your goal of the treatment of extracorporeal liver support, of course. So I think that I hope that everyone can use this kind of anticoagulation, that it's really the best choice, I think.
But
Yes,
have,
yes, this is quite important, that citrate is better. And if you use the circuit with citrate, you can keep it open functionally 3 days. So you can use another CytoSorb after 24 hours if you have the citrate. These, in my experience, never happened when we were on heparin, even with 83. By time it was clotted. So citrate is better. And because of the CytoSorb, you have an endothelial improving. You have kidney function improving, which means citrate metabolization. You have oxygenation improving. You have everything improving. So it means that even your failing liver, oxygenation, blood flow will improve. So do be not aware about citrate problems, because you improve your patient, you will have a better metabolization every hour.
Janos, I think that's a nice summary. Thank you for that. Thank you, Ivano. I think we can say, maybe when looking at the title of our webinar, actually it's easy, but it can be sometimes challenging if we don't do the right things. Would you agree on that?
Yes.
Yeah?
Yes, it's challenging.
Yeah.
Like always in medicine. Without monitoring, we have a great problem, of course.
Yeah, with that, a big thank you to you for these wonderful presentations, for this wonderful overview. I think, I hope we all learned a lot, and with that, I really like to come to an end of our webinar today. I like to thank also our team, our CytoSorbents team, and of course a big thanks to all the participants all around the world. And again, if you like to get a certificate, please stay with us. And you see here the quiz or the poll. So in case you mark yes, of course, then you will receive a certificate via email. So yeah, with that, I like to take the opportunity also to let you know that we have our next webinar already next week, 13th of September. It will be about septic shock individualized treatment with CytoSorb, a very interesting topic, and we've got Professor Jean-Louis Vincent and Professor Joel Molnar for this webinar, and I'm quite happy to moderate that again, and to welcome you all in case you have time. So, and with that, I really like to say goodbye. All the best to you. Thanks a lot, and stay safe.